Good afternoon. Can you all hear me okay? Okay, I can hear myself quite well. I've been listening to myself for too long these years. Okay, well, this is going to be an awesome session. So I just want you to know that once you're in this room, you're stuck here. You can't leave. Okay? I'll call you out if you do. I'm just kidding. No, but if this is going to be a very relaxed session, welcome. Have a seat. There's some in the front. Feel free to raise your hand, come up to the mic, ask questions, things you don't understand or you need to know more about, write them down. We already have a question. Just kidding. It was just I just want you to feel very comfortable because this session is intended for us to talk really deeply about harm reduction, right? And the only way we can do that is if we get all of our fears out and talk about the challenges that we're experiencing every day, right? If we're going to have supportive housing programs, we know that people live in those programs and that they're going to struggle with substance use, and they're going to struggle with mental health issues, and they're going to struggle with poverty, because poverty sucks, right? So, and we're going to do things in these programs to survive, right? We're also really well positioned today because we have peer advocates, we have folks in harm reduction and substance use treatment here, we have folks that have been running programs in supportive housing for decades, and we have some newbies like myself and that just started doing housing first and are working towards great models. We also have the privilege today of having a gentleman with us who is a tenant in our supportive housing programs. So, you know, this session, like I said before, is going to be an awesome session, and I dare you to leave. Okay? So let me introduce myself, talk a little bit about what we do, and then I'll hand it over to my folks next to me. My name's Nick Coulter. I'm a social worker. I'm co-founder and chief of development for Person-Centered Housing Options. We're in Monroe County, Rochester, New York, for folks that may not know where that is. We're just a little bit north. Person-Centered Housing Options was founded in 2015. We do homeless outreach. We do housing first, both scattered site and now single site. We're very lucky to work with Home Leasing, who is also here with us in this room, to do single site. And we also do care management using Health Home or Medicaid fee-for-service. I think we're uniquely positioned as a moderator to have really deep understanding conversations about what is it like to do harm reduction with somebody who's just moved off the street into an HCR property and is struggling with opioid use. Like, let's just talk about that, right? So I'm lucky to be here today, and I'm just thankful for all of you. So give yourselves a round of applause, I guess, for making it through here today. I hope that the food settled in your stomach and you're able to stay attentive, but we'll shake it up a little bit here and there. I want to introduce Keila. She'll talk a little bit about herself, and then Chet from GMHC.
Hello. Hi, everyone. Thank you, Nick. My name is Keila Morales. I am a licensed social worker, and I am a managing director of clinic operations and compliance at Gayman's Health Crisis. So I have administrative oversight over programs, and I work specifically with our harm reduction services.
Good afternoon, everyone. I don't know why I'm tempted to say good morning, but good afternoon, everyone. My name is Chet. I am the managing director for mental health and substance use services, and I have clinical oversight of all programs. Prior to me being in my current role, I was at Harley United, where I had several different roles, where I was in housing for quite some time. I eventually went to a day program. I also have experience with managed care, and I'm currently at GMHC.
Okay, those are the folks from GMHC. I'd like to introduce you to Amy LaFountain from Joseph's House.
Can everybody hear me? Yes, Amy LaFountain. I'm the new executive director for Joseph's House and Shelter for about 3 months, but I've been with the agency for almost 18 years. So our mission is to provide non-judgmental services to end homelessness. And we're in Rensselaer County and Albany County, and we provide shelter, a really robust outreach program, and scattered site supported housing and site-based supported housing.
And I gotta say that if you ever want to see how sheltering and housing first and outreach looks, these are the folks to go to. Amy was really, really amazing. And her previous executive director, Kevin, supported PCHO in our growth, and I can't thank them enough for their education and their skill set. They really do an amazing job. I have two amazing folks from Person-Centered Housing Options. Chris, do you want to introduce yourself? And then Stephanie, our peer housing advocate.
Hello, my name is Christopher McClary. I've been with Person-Centered Housing, Flower City Apartments for about 4 months now. I'm about 6 months homeless before that. So and did about 3 stints in my life of being homeless, and to have the security and stability of Person-Centered Housing apartment has changed my life. I just completed school, got my CDLA through their program, and on to a new life.
Stephanie?
Hi, my name's Stephanie. I am a peer navigator. Sorry, I'm really loud. I probably don't even need
What's
the mic.
new?
So I am a person with lived experience with substance use disorder, homelessness. I was homeless on the streets of Rochester for about a straight 5 years, off and on prior to that. I've been arrested. I've done all the things, and came out on the other side, and now I get to work with amazing people like Chris and Nick. So no questions are off the table. Please help us learn from you and each other.
Yep. All right. So I told you, I promised you that this would be an awesome session, right? Okay, so how this is going to work is that GMHC is going to do a presentation on harm reduction for about 20-30 minutes, and then we're going to do just question and answer panel discussion with our other presenters here, and then we'll kind of open it up to you folks to ask questions. Really, like Stephanie said, no question is off the table. So let's dig in, let's have some fun, and Chet and Keila, take it away.
Great, thank you so much. So good afternoon, everyone. Again, we've been sitting in these trainings and these information gathering sessions, talking about housing as being priority. Housing works. Oh, sorry about that.
Just bring it up closer to you. You can move it. There you go.
We've been talking about housing being a priority, housing works, but also housing is harm reduction.
Amen.
So today we'll be discussing harm reduction, stigma and barriers to treatment, substance use, and how harm reduction looks at GMHC. So what is harm reduction? Harm reduction approach looks to reduce the negative consequences of substance use without necessarily reducing the substance use itself. It emphasizes engaging directly with people who use to prevent overdose and infectious diseases, transmission, improve physical, mental, social well-being, and offers low barrier options to accessing healthcare services, including substance use and mental health treatment. So some key principles: non-judgmental approach when we are working with our clients, accepting behavior changes as an incremental process, inclusion of individuals in active use recovery within the community to shape policies and practices. It focuses on quality life improvements and an empowerment of the individual as a primary agent responsible for reducing the harm related to their substance use. We also need to recognize that all individuals have the right to be treated with respect and dignity, regardless of their choices or behaviors. And for us, adopting an accepting and compassionate attitude towards individuals, but also shifting the focus from a sole emphasis on complete abstinence to setting realistic and achievable goals that reduces the potential harm associated with substance use. And lastly, I would like to share recognizing that clients are the expert of their own lives and experiences, and involving them in decision-making process, goal setting, and treatment planning.
Moving into some harm reduction approaches. So when we think about harm reduction, how can we equip our supportive housing staffing with being able to provide harm reduction services? So thinking about mainly Narcan. We all have heard about Narcan, how it can save a life, how it can be very personal to you, not having to connect to another provider. It can be your family member, it can be your friend, it can be someone who lives right across the door from you that is able to recognize the sign, has the kit, and is able to save your life. And also connecting with those community providers that can come in and provide that training if those dispensers are not, if you don't have trained dispensers within your supportive housing program. Peer support programs, bringing in individuals that are at different stages of their recovery. So not just looking at someone who has not been using for a certain amount of time and has like this more of an idealistic place of where they are, but have been through the trenches and are still within their recovery. And knowing that it doesn't look just one way for one person, and there will be that time where you haven't been using substances for some time, and then you may go back to using substances, and what that looks like for everyone and the journey. So having those peer supports in place, or having that collaboration with other programs in the community that can provide those for the residents. Supply and distribution recovery programs. So that's fentanyl strips, xylazine strips. Clients having access to those and not needing to ask for them, but having easy access. I can just go to this program and I can get them, no questions asked. At GMHC, we do provide these to our clients where we do not collect any demographic information. You need a fentanyl strip, you come to us, we'll provide it for you. So that helps with someone not feeling stigmatized, not having to share, what they're using or having it attached to them, just having access. Supervised consumption services. So being able to go to a location where they can safely use. So we just opened our first one in New York City. So giving that information to our clients that they can safely go to these places, they can use without judgment, and also be connected to services. We might not feel comfortable telling our housing case manager that we're using substances or that we're experimenting with substances. So at least knowing of the places nearby that we can go to engage in our preferred activities. Of course, we have the opioid dependency treatments and always having a person-centered approach. Meeting everyone where they are at. Substance use, it may be that at this moment I am not ready to stop using my substances. I may know the negative effects of using the substances, but I'm not ready to quit. So how can I best use and not feel as though I'm being judged, and also knowing that I am doing so in the best safe way for myself. So having clean access to syringes. That is also another key access point. If I am injecting substances, do I have access to those clean syringes, or am I sharing with friends and family? So also being educated on that. So thinking about some risk factors that we may have as individuals that will lead us to use substances. Stressors that we have in our everyday lives, things that are coming up, job losses. With COVID, there's been a lot of job losses. There's been a lot of family loss that we've experienced, and that leads to us increasing our substance use. And also not having access to resources. There have been a lot of programs that are at capacity, long wait lists. This is also a stressor that leads to our increase in substance use. Co-occurring physical health conditions, untreated mental health illnesses, as well as a lack of social support and also social acceptance. So things to be mindful of. So as we're talking to our clients and also educating, think about your changes in tolerance. Let's say I haven't been using for some time, and now I'm going back to using, and I think that I can use the same amount that I was using before. That is not the case. Our body will react differently. So just an individual knowing that, not everyone will know that. Everyone will think, oh, I'm already used to this. No, you need to taper up your use so that you have, it's a safer weight to use, and you see how much that your body can manage at this time. The mixing of drugs. So whether you are aware or not aware that you're mixing drugs, as most of us may know, there is a lot of lacing that is happening with different drugs. So you may just think that you are smoking weed, but it is laced with fentanyl, right? And that can lead to a fatal overdose, right? So knowing that you have the access to fentanyl strips, I can test my supply. I can see if it is safe to use. The drug quality, that goes back to the other point I just mentioned. A previous non-fatal overdose. So if you've had an overdose before, knowing that your likelihood for another overdose while using that substance is at a higher chance. And also using alone. Not having anyone around you when you're using the substance is a higher rate for you have a higher rate of having a negative outcome. So giving them the resources of, sorry, I'm going into my, is that it? Okay. So giving them the supports that they need. So never using alone. There is a hotline that not many people know of, that if you are using a substance, you can call this hotline. There are peers, volunteer peers that are attending to that line that can be on the phone with you while you are using these substances. And if anything were to happen while you are using, they have access to emergency services to get them out to you. And then here we just have some statistics on substance use, the most commonly used substances in the United States. This is based on the 2021 survey, ages 12 and older in the past year. So as you can see, marijuana being at 18%, and us knowing that there's a lot of lacing with drugs, so being aware of that, and then also the misuse of prescription drugs, following with 5%. These statistics are based on New York, and this is what we present when we are providing our Narcan trainings to individuals. So seeing that every 3 hours, someone is dying of an overdose in New York City. More New Yorkers are dying of overdoses than homicides and suicides. Fentanyl is involved in more than 76% of all overdoses. And opioids are involved in more than 80% of all overdoses. Mm-hmm. Okay.
So research has shown that compared to homeless families, homeless single adults have higher rate of serious mental illness, addiction disorders, and other serious health problems. And also 34% of sheltered adults who were homeless have chronic substance use issues. Most research also shows around a third of people who are homeless have problem with alcohol and or drug, and around 2/3 of these people have lifetime histories of drug or alcohol use disorders. Stigma and barriers to treatment for substance use are significant issues that prevent individuals from seeking and receiving the help they need. It is important to understand the impact of stigma and barriers to treatment to develop effective strategies and interventions to address these challenges. Stigma refers to negative attitudes and beliefs directed towards individuals with substance use disorders. The stigma associated with substance use and substance use disorders can lead to discrimination and social exclusion, causing the individual to feel ashamed and isolated. Stigma can also prevent individuals from seeking treatment due to fear of judgment and rejections. Barriers to treatment for substance use includes financial, logistical, and systemic challenges. Financial barriers may include a lack of insurance, coverage, or high out-of-pocket costs for treatment. Logistical barriers may include difficulties accessing treatment due to lack of transportation or childcare, and systemic barriers may include shortage of treatment providers or inadequate resources for treatment.
The benefits of harm reduction in housing. Sorry, let me just catch up on my notes here. All right, yeah. So some of the benefits when applying the harm reduction approach, improving the health outcomes of our residents, reducing the public health costs, increasing housing stability, and improving the community safety. So some of the practices for harm reduction in housing is providing, again, going to some of the points mentioned before, providing that education and training, regardless of them reporting any substance use, but making that training and education available to the individuals for them to receive. As we noted earlier, not everyone will report their substance use or they're experimenting with substance use, so it's always good to have that knowledge available for them. Implementing policies and procedures to prioritize their safety. So that can be with the Narcan kits, securing that everyone that you're placing within your housing facility has received the Narcan training and is aware of how to recognize the signs of an overdose. Offering a range of harm reduction services, whether that be on-site or in collaboration with a community partner that is meeting your residents and providing those services to them. Fostering a supportive and non-judgmental environment. That goes back to stigmatizing language. So training staff on how they're speaking to residents about their substance use, the questions that they're asking, also how they're responding to maybe some of the questions that residents have about their substance use or about connecting them to substance use services. It can be as small as body language and facial expressions. And also making sure that you're engaging in an ongoing evaluation and quality improvement of your program. Sorry, there we go. Some additional things would be a resource library. So having a place where, again, residents are able to go without having to interact with any of the providers. They can just go ahead and grab the information that they need. And the words that we use matter. How we refer to residents matter when we are speaking about substance use. So looking at how harm reduction looks in our housing facilities, so currently we have HOPWA and HUD housing. So all of our case managers are trained on the use of Narcan, and they have a kit when they're making house visits in the case of any emergency. In weekly one-to-one check-ins, our case managers assess supportive needs and are open to discussions about substance use, mental health, and also collaborate with our harm reduction services or mental health department for additional service needs.
So, as Keila mentioned before, all of our employees are trained on how to administer Narcan. We also provide that training to our clients as well. Narcan trainings and kits are available for all clients and community members. We also provide trainings for our community members as well. If someone needs trainings, they can reach out to us, and one of our staff person is able to provide that training for them as well. Syringe dispense wall mounts are docked in all of our restrooms. We do also have a expanded syringe access program where we have an outreach worker going out into the community and providing vouchers to clients who are in need of needles, and they're able to get those needles at our facility in our clinic. Keila mentioned earlier fentanyl test strip. That's something that's also available to our clients. And of course, access to PrEP and PEP services. We do have a pretty large testing and prevention program at GMHC, and we do a lot of testing, but also making referrals for those services as well. And harm reduction individuals, groups, and counseling are being provided in our programs as well.
All right, so some key takeaways is to recognize the importance of harm reduction as a critical component of housing, developing a comprehensive harm reduction strategy for each of your housing programs that includes harm reduction education and access to resources and services, addressing stigma associated with substance use and mental health, and fostering partnerships with community organizations and service providers to offer a range of these services. So some of the next steps is conducting a needs assessment to identify the needs of residents and gaps in services, developing a harm reduction policy and procedure, providing training to staff on harm reduction principles and practices, and conducting regular evaluations of harm reduction services to identify areas for improvement. Those are some references. Back to you, Nick.
That's my cue. So if anybody needs any information, wants to know where some of this information came from, Keila and Chet will be available for questions. There's also a reference slide that they have if you need to ask them questions later. That was a lot of information to take on. If you haven't started to do harm reduction, or you're thinking about it, or maybe your program model is adjusting to the changes in our communities, they are a wealth of knowledge to access after our program. Kayla's messing with me. That's okay though. It's all right. We don't need to go into depth with that with the PowerPoint again. But anyhow, so this portion of our presentation or session is just really conversation. But I want to highlight a few things that Keila and Chet mentioned. If we know that in our housing programs or in the population that we serve, 30 to 40% of the people that we serve are experiencing chronic substance use, how do we position ourselves? If we want to increase housing stability and increase health outcomes, and then we want to increase our relationships with other providers, healthcare providers, and invite people into our doors, who do we go to? How do we do that? So those are the questions that I ask you all to start to think about. And where do the tenants that are in these programs that may be in different parts of their journey along abstinence or reducing their use of substances, where are they in that process of developing the program that we're working on? So I just want to have a couple, I have like 10 questions that I've developed over the last couple days. But your questions matter too. So if you have questions, specific questions, you can certainly come up to the microphone. Or if you need assistance, we have a volunteer and person working, a couple people working the back there. But I did have one really big question for our panelists that I wanted to ask. So for Stephanie, Chris, and Amy, can you describe what harm reduction looks like in your day-to-day work and life? And we can just kind of go down the line.
Okay, I'll go first, Amy. I would say the day-to-day of what we do with harm reduction is every single day just continuing the relationship building with the tenants. Because it doesn't matter if everything is available, if there isn't the relationship, a person isn't going to ask, inquire, share with you. So every day, it's just building that relationship with everybody who lives within our housing programs.
For me, it is staying busy. I'm coming up on 10 and a half months clean. And but as Nick said, all the tenants are of a different phase in their recovery. And I try to not, and there's also people that are actively dealing that might make it into some of these housings. I try to pick and choose who I associate with, and if I don't feel comfortable, I go find a peer advocate or housing, or find a meeting, or find my higher power, and get back to being centered on my addiction and keeping it at bay.
So I wouldn't be here if it wasn't for harm reduction. So I'm a huge advocate for it. I think not only the peers working within these housing units, we're learning harm reduction and getting tools from the people we're serving just as much as they're getting it from us. Harm reduction is getting people to volunteer. We have an in-house food cupboard, and people will come with us to pick up and then fill the food cupboard. It's building community. Harm reduction is recovery. It's part of that journey. It's little things that we don't think about that we're doing, that we're implementing, and whether it's buckling our seatbelts or moderating our use, or going from injecting to snorting. Those are huge, huge things that should be celebrated.
Awesome, thank you.
Yeah.
In reviewing what GMHC shared, the techniques and some of the information that they shared, is there anything that really stood out for the three of you that you use or that you want to talk about more and expand on? You decide who goes first. You can rock, paper, scissors, whatever you need to do.
So the thing that stands out to me, and I believe this to be true with all of my heart, that housing is harm reduction, and 100% of the time, people in housing use safer. Like, there's not a time that I don't see it, and it's helping people to see, other people to see that the smallest change is change, and that we have to measure success and progress differently, and that what progress and success for one person might be so far from what would be expected of yourself or somebody else. So that housing really is just the centerpiece of some of the foundations of harm reduction.
How about you, Chris?
Well, in 30 years of using drugs, I sort of isolated and kept people at bay so they didn't know of my addiction and didn't know of my problem. But now in here and even in the homeless shelter, I found family, I found friends, I found people to help me fight the battle, and it's helped, and that's where I stand today.
I love how it was brought up, like, the harm reduction tools that we have available to us, whether it's naloxone, safe injection items, safe smoking kits, condoms, testing strips. These should be readily available without someone having to come to me or go to my boss or a housing stability coordinator. They should be able to just grab them. And we should be encouraging that, because that's a huge part of finding recovery and finding our worth, because in the beginning, like when I was in active use, I wouldn't think twice about picking a needle up off the street and using it. And then slowly I started utilizing the needle exchange program, and I baby stepped forward and eventually found what worked for me. And it's not always AA or NA or, you know, it can be the gym, it can be service work. There are so many different pathways, and I think honoring those pathways and honoring harm reduction as a part of recovery and a pathway is a huge part of the movement.
Can you talk a little bit about your door?
Oh, my door. So my door is littered with all the things. Like, I have all the resources from, you know, finding warm food or food pantries, all the AA, NA, HA, Naranon, recovery fitness, like all of these different calendars for events and things you can do to get involved with the community. I have Narcan taped to my door. I had fentanyl test strips taped to my door, which I had to move into my office behind the closed door, which I'm not a huge fan of, and I'm just going to keep advocating and working towards like that being such a huge part of helping people save themselves, because we're only part of, we're walking beside them, and we know what we need. We sometimes just need a little help coaxing that out and like speaking it out loud with our peers to figure out what our next step is. So yeah, we just keep advocating and fighting the good fight for harm reduction and everything underneath that umbrella.
Awesome. So I just want to pause for a minute. Any questions from the audience or thoughts? I have tons, so don't worry. I can come up with some. Yes, sir. Jose.
Yes.
Yeah, I can see your badge.
Yes, I have a question. How do you restore the harm that's causing community once you're using drugs or stop using drugs, or for the system that is helping people stop using drugs? How do you restore that harm?
I was going to re-say his question, but it's too complex. Do you want to use the microphone real quick so people in the back can hear? I think, how do you restore the harm?
Right.
But then there was a bunch of stuff afterwards.
Right. So, you know, historically, you know, drug use has been around for a long time, and it has caused serious harm to community. How is that restored in your program? How do you restore that harm in community? For those that use drugs or sold drugs or do the work helping others, how do you bring that together?
That's an amazing question. So for me personally, I do a lot of volunteer work within the community. We go out and we pick up needles. We offer support services, and we have impacted people who are either currently unhoused or currently using volunteer right along with us, and they're doing those same things with us. You know, the war on drugs, like, I can't swear, can I, right?
I think you can swear. I think if this is the room you can swear in, this is the one, right? Like, let's just do it.
The war on drugs created a shitstorm, right? Like,
That's not even that bad. I was
insanity.
expecting a lot worse.
And it's pinned people against each other. It's created barriers, and it's made it impossible for us to not only serve people, get people into the right programs. So I think what I love about person-centered housing options is we're encouraged to walk the line and like
Amen.
ask those hard questions and get involved with the not always pretty part of it. And whether it's having a conversation with someone about, okay, can we pick up your apartment and safely discard of these syringes together? Or, you know, let's do some outreach so we can see how not necessarily calling people out, but if we go out into the community they might see, oh, wow, okay, I'm doing this stuff too. This is how my behavior is kind of spiraling into the community, and these are things I can do different. Instead of dropping my syringe down on the ground, I can pop it in the needle container that I have that fits in my backpack.
I think from a development standpoint, in terms of like how we approached housing, so if you're a developer or you're a nonprofit that's working to do like Empire State Supported Housing Initiative or creating programs like myself, I think finding a development partner, our partner Home Leasing said to the city, and we just had this conversation earlier today, said to the city, give us the worst buildings you could find and the neighborhoods that we went into fearlessly are down the street from the largest drug selling locations that you could find. We weren't going into neighborhoods that were quote unquote safe. We're going in, we're going to attack this problem, and we're gonna do it right next door to wherever we need to do it. And I thank Brett and our home leasing team as our construction and development team to go into these neighborhoods and say, hey, Nick, we want you to come with us and fight this problem right there down the street. Like, so if there's one way to do it, is just to get in and do it. So I think that's, to answer your question from a development standpoint, is to not be afraid that the neighborhoods that are struggling the most are the neighborhoods we should be in, and stop skirting around and finding neighborhoods that are less, drug-ridden to work in. So, I mean, we've got to tackle it. So, I don't know, Amy, do you want to add anything to this question? I saw your face kind of light up, but.
No, what you were saying about the communities that we're in, we're in a variety of different communities, and it's having the community get to know the people that we're serving, because I don't know, it just goes back to that like relationship and telling people's story, and having the community meet the person and actually know them as a human being.
Great. We have a question back here.
I just have a question. I just want to find out, like, primarily who are being served. I'm from affordable housing, and I see that mostly the senior tenants are the ones that are using the drug, actually on drugs. And in terms of harm reduction, I mean, for affordable housing, as opposed to GMHC, I would like to know, like in your organization, where are the numbers at in regards to, people who are benefiting from harm reduction? And also from the participants, I want to know, is it the program that really helps, or is it your own self-conviction that helps to make the program work?
Okay, so we got a few questions there. Let me talk a little bit about numbers. So PCHO is about 8 years old. Across scattered site and single site housing, I would say about half our population of folks that we get in are over the age of 45. And then it starts to lower as you creep into the 60s, because unfortunately, folks that are chronically homeless are more likely to die earlier. And so we focus primarily on the chronic homeless. Our population of supportive housing numbers is specifically targeting the chronic homeless, because we know with chronic homelessness, we have one of the most vulnerable populations, and that spans, domestic violence, mental illness, substance use, older adults, et cetera, et cetera. So we went into this specifically to attack the chronic homeless issue. We do find that our older adults in Flower City are some of the most vulnerable and are using. However, I would say, I'm thinking of the numbers right now in my head, just to give you kind of a picture of what Monroe County looks like in terms of Rochester and the work that we do. In our outreach, we find and house roughly 200 households a year. We're 1.7 million county in terms of residency. We have a 8-person outreach team, and we cover a very large group of people. So we engage about 300 plus households, and about 80% of those folks will get off the streets and into our housing. So, and about 90 to 94% of those folks that get in our housing stay in our housing. But it's because of the work that Stephanie does that we do that. So I hope that answers a little bit picture of the numbers. I would say about 40 to 60% of the people, depending on which program we're talking about, whether it's scattered site or single site, will come into our housing having a pretty unfortunate substance use problem. But that starts to drop immediately upon entry. We have one gentleman that would repeatedly go into the ER for alcohol use every day. And his provider said to us, like maybe was it last week or something like that, that he hasn't been in the hospital in over a month. Well, that's a great success, and I think Amy has these same stories. So that's kind of what it looks like. We don't expect total abstinence right out the gate. It may take a year, it may take longer, but we definitely see a reduction in numbers in terms of use. Anything you guys want to add to the number part?
No, but I want to add, like, some people's recovery might not even be total abstinence.
Right.
And that's totally okay. They're, some people, their drug of consequence might be opiates, and they can drink. Or some people might recreationally use Molly, but they can't drink. And so that's okay. That doesn't negate their journey and their path and all the progress they're making.
Right. Anything you want to add? Did we answer your questions? Was there anything I missed? Okay, all right. If there was, we can always come back. Yeah. Or was there another question over here before? This gentleman had his hand up, so I'm sorry if I haven't kept track of them.
All right, I'm from a smaller city in upstate New York, about 50,000 people, Binghamton. We run several homeless programs.
Broome
up
County.
there. Broome County.
Amen.
Southern tier. We also run a syringe exchange as well, and my friend asked a question about healing with the community. Some of the police departments and some of the, administrative buildings don't necessarily see eye to eye with the way that, we see things in this room. So do you have any suggestions or guidance of how we can kind of mend that relationship with,
What's your name?
Anthony.
Anthony, bring us down. Let's talk to your administrations.
Well, we've actually had laws passed in a neighboring town where syringe exchange is held, where it's really handcuffed us where we can't move to any other site in that town because of certain restrictions that they've put in place of the syringe exchange being too close to residential buildings or schools or libraries or things of that nature. The police department surveils the area a little higher than other areas in our city. So we're seeing all sorts, different angles of it coming to us where, like I said, we can't lease in a different building in that area. We'd have to move to a different town. So, it's clear that they're trying to push us out of that area. So I don't know how we can kind of show them the good that's being done, or besides the Narcan numbers in the area of lives that are being saved. But I don't know.
Do you have friends at the library in Broome County?
Yeah.
Okay. So I think it's Josias Bertram is your library administrator, and he is doing some really amazing work in your county, combining homeless outreach with the library. And I think as talking with people that are like-minded and engaging this population will be really helpful to you, but I have this sneaking suspicion that Amy here has great ways to engage community that are obstinate in housing development as well as needle exchange, because she's been through this before.
Well, so in Rensselaer County, something extraordinary has happened, and
Can you talk a little bit about Rensselaer County and the small size of it? In
Rensselaer
terms of
County.
Troy?
Oh gosh, the city of Troy is 40. God, forgive me,
Same size.
40,000 people. On a monthly basis, the Commissioner of Mental Health for Rensselaer County and members of the police department meet with providers like myself together each month to talk about the successes and the challenges between those relationships. And a couple times a year, the Troy Police Department puts on a training at our community college, the Emotionally Disturbed Person Response Team, and they train the Troy Police Department as well as other local criminal justice service entities on how to better navigate mental health crises and to normalize language. And I've had the opportunity to speak at these trainings, and it's been pretty extraordinary that that we've developed a really great relationship where we're not navigating those types of challenges. But mind you, I mean, it took a long, long time, but we've gotten to a pretty extraordinary place.
So you have friends at the library, get people together. They have security officers at the library that are also police officers. And those police officers are learning from the outreach workers. And so I think taking what Amy shared and what you already have in your county might be a solution to engaging those populations that have a really hard time understanding what harm reduction is and then building community with them. So that, and you want to, yeah, go ahead, Stephanie.
So, I mean, I would suggest going rogue. Like, outside of things that you can't do within your paying position, you can do as a human. Whether it's throwing on a backpack and loading it up with harm reduction items, like I do on my volunteering on the weekend, and calling those people out, because that literally kills people. You know? So don't be afraid to call them out. Don't be afraid to tag other organizations in for support in calling out that type of discrimination.
I hope that answered your question. Okay. Yeah.
I was just going to add to that. So in New York City, we get a lot of NIMBYism with our supportive housing buildings. And the community boards fight us a lot. And the ones that are fighting us the most end up being our biggest advocates in the end, because we engage with them. We often, in our buildings, will have a space we say you can have your monthly meeting here. And a lot of that, I think, is based off fear from their own experience with people in their life that they've experienced, different things with, and just not having the knowledge. So I always say community boards they don't have a voice, but they have a huge voice. And so engaging with them. And then what we also do is we work with our police officers, and some groups have done this really well, where they will call them personally if something is happening with one of the tenants, and they've gotten to know those tenants, so they also don't have that fear as much, because they know the building, they know who they can count on, and they know the tenants better. So just that kind of engagement again.
Okay. We have more questions. Awesome. Let's keep it rolling.
Thank you. I was curious, in community housing, reducing harm as an individual, maintaining sobriety, congratulations, that is an incredible feat. I'm curious what some things are that staff is able to do to help on a community level and with the individual, like some things that work.
For me?
I think she's talking to you, Chris.
What things have worked in the community?
It's maintain sobriety specifically within housing, that, when there is use around you, but you're able to veer away from that.
I've been fortunate to there's quite a few elderly and disabled people. Even in my addiction, I was a Boy Scout, I was a Cub Scout. I was taught by my family to help others. And even in my addiction, I tried to help others as I went along, because I felt guilty about my addiction. So now that I got in here and got clean, volunteering for the food pantry, going to help to get the food, going back to the homeless shelter, volunteering there. I go back to church every Sunday, made my peace with my God. But trying to help out, and if I do feel down, I've made friends with all the people in the community. It's a small community. I'm not from Rochester. I'm from Buffalo, so I had to change my people, places, and things to get into a new area where I didn't have a comfort zone. I didn't have my connections of 30 years, my dealers, my friends that wanted to use with me. So I changed just about everything, and to have friends around, and just to keep myself busy and today you guys are helping me get another day under my belt. So just keeping busy as much as possible, and if I need to, I have Nick, I have Stephanie, the other housing staff there. It's just, otherwise I don't know where I'd be. It's been 3 months since I got in there, and it has changed my life. It saved my life, actually.
So just in, go on. So like we think sometimes with getting folks in housing, 3 months is nothing, but in that 3 months, that's what Chris has done. And when he referred to the folks that are older adults or that are in the housing programs, a lot of those folks were chronically in some of our local shelters, House of Mercy, which some of you folks might know, long term. So these folks were coming out with ailments and issues, and Chris has made it his point to make them part of his community, especially folks that have struggle getting up and down the stairs or don't go out and go shopping. So the food pantry helps with that. But Chris also helps with that too, because he knows, oh, my neighbor, I forget her name, Kathy, or Barb, has a hard time. So I mixed it totally up. So
Keeps me clean.
Yeah. Other questions? Yeah.
You mentioned that you run a scattered site housing program, and I was wondering if you have any strategies. We have a scattered site housing program in New York City. We have units specifically for people who are actively using, and these are some of our most vulnerable tenants when it comes to other people sort of moving into the apartment or other activities in the neighborhood that frequently make them feel unsafe and then want to leave.
Well, that's a great question. I'm going to pitch this question to Amy because Amy also has scattered site, and if Amy doesn't answer it the exact same way I will, just kidding. I'll jump in and help out with some other stuff too.
Landlord engagement. So some of what we do around harm reduction, I think in all areas of the agency is normalizing language. And so again, it's building the relationship with the landlord. And if one landlord is happy with collaborating with the agency, then maybe they'll rent to us, more than one apartment. Maybe they know other people who they will, share their name with. But landlord engagement, being candid, I think that's what has helped in a lot of areas. Just as an aside, like interviewing, I interview much more candidly now. So engagement with any service provider, landlord, I'm much more candid. So that people are more aware of the relationship that they're entering, and so that there is better communication if something does happen where you haven't covered it up as if it doesn't exist, and that has tended to be successful.
Yeah, just from a program standpoint, we built our programs. We're lucky to have built our programs in this past decade, where funding streams have altered a little bit, and it's been very helpful. We've built our programs around landlord needs in our local community in order to reduce some of the challenges that they would normally face. So a lot of other programs in our area won't provide security deposit. or they might not pay for damages, or they don't realize that we, as leaseholders, we are master leaseholders, that we can move from one unit to the next unit and still rent the previous unit. So we built the program financially around the needs of some of our landlords. We also were very candid, like Amy said, with our property owners to say, listen, here's what we're doing, here's how we do it, here's the population that we're serving. You're part of the solution. As we rent more units from you, you can go buy more buildings. Let's be real here. And the people that we're serving are people that need us the most, and you'll be impacting the homeless population in our community. Is that something you want to jump on board with or not? Because if you don't want to, we don't need you. We'll go find other people. And we've built like 5 to 10 really invested property owners that we have multiple units with, that we honor on an annual basis. I learned that from Troy, from Joseph's house. We give them, awards and honor the work that they do. They come to our annual fundraiser. I mean, we really work with them. And then our staff are constantly checking in with them, weekly going to clients with very high needs, working on site with buildings that we rent more than 60 to 70% of the building. We have a staff member that hangs out there, and we might take one of the apartments and use it for an office. So just being really nimble, developing in ways to supporting those property owners, and then we go to neighborhood association meetings and hear from the residents, where we have high concentrations of people living, so that we're able to tackle those issues, and partner with the captains of our different police department sections. I mean, all of that stuff. So, we're affecting relationships in the community, and that makes its way back into the home.
I'm sorry, I think I didn't state my question clearly.
Sorry. That was a really long answer for that.
Yeah, the issue I'm bringing up is frequently in our scattered site units for folks who are actively using, they have other folks move in with them.
Oh, that's fine.
Who take over the apartment.
Yeah.
And so do you have any strategies to support those tenants?
Oh, that's the good stuff. Okay, so, and sometimes those are dealers, right? They love taking over apartments. They're the best people in the world. Oh, God. Strategies, guys? I could go on. I could come up with some things, but I don't want to get in trouble.
That's really hard. That is really, really hard. And so our scattered site apartments, the tenant is the leaseholder. So a lot of times, some of that navigation really comes down to what the landlord wants to do. If they want to pursue eviction, and it's up to us to talk to the tenant and really talk to them about, how much they value their housing, and to potentially make some different choices in who they're allowing in. But it looks very different probably than what you're describing as the master leaseholder. But that's a really difficult situation.
Yeah. Do you want to share? Jump in, man.
It's important to invite them into a learning space where they're learning about the harm that they're causing. Right? There's restorative justice circles where you invite the drug dealer to hear the stories of the people who are affected by the drugs, to learn and feel what the family members feel. That's a way that you can bring community together, but also educate community to see how they impact each other.
Yeah, and if you're talking about folks so there's all different kinds of folks. My girlfriend moved in, my brother's uncle moved in, the homeless guy that was sleeping next to me at the shelter moved in, and all the above. So, we have a care management team that engages those other individuals that moved in and starts working with them on a housing plan, getting them out of there. We don't. Obviously, it's a lease violation in some respects where the person's moved somebody in without consent, especially if we're the master leaseholders. But we also realize that person is just trying to survive as well, right? So it's really big for us to engage that person in getting their own apartment. And that may mean under some of our local rules, and you probably deal with this as well, now that they've moved into their friend's apartment, they're no longer homeless, right? So we have to partner with a shelter or get them into a hotel placement and make sure that they continue their homeless status, and they know that we're with them on that journey. We're not going to abandon them. So our outreach team steps in, gets them out of the apartment, gets them into the shelter, or maybe they go back on the street, but they know that their own end goal is to get their own apartment and not be with their friend who just, happened to find his way into an apartment. So those are a lot of strategies. And then as much as it is challenging to deal with the police and to partner with them, on this front, it is often helpful when violence or severe drug dealing starts to take hold of an apartment. So I have a lot of friends in the police department to help me handle those issues if we need to. We had one building, the whole building got taken over, and they were dealing out of different apartments. So we had a sting operation. So sometimes you gotta get your clients out and take care of business. That's life, though. Okay, that was uncomfortable. So for our scattered site housing, we rent apartments all over the county. So we might rent from an owner who owns a property with 19 units, and the dealer moved into 3 of them. You got yourself a problem. So, and then other people move in, you got to fight it. So, yeah, they're just using our clients to do their job, right? They'll pay our clients to leave for the weekend, and they take over the apartment, and they're gone by Monday. Yeah, but, that's why building these relationships with people like Stephanie, who know that process, see that happening, we can prevent it from happening by looking out for the signs. Somebody's like hanging out with you a little bit too much and they're taking advantage of you. Can we talk about that? Stephanie will see this stuff happening before it even happens. So hire the right people.
I got one question.
Yeah.
Do you guys still provide financial management for clients? Because I used to refer my clients to GMHC all the time for financial management, because when they get Social Security, they don't pay their shit. So they used to sign the check over to GMHC. GMHC would know how much they have to pay the landlord, $240, $230.
Yeah.
Back then it was like $185, because the checks were 6 and some change. Now they're 8 and some change, so it's like $230, $240 a month. They don't pay it. So do you guys still do the financial management side when you refer a client to you, if they're in agreement to sign their check over to you, you'll pay the landlord and then give them what's left?
So I'll let GMHC answer that specific, but then we can talk about financial management outside of that.
Yes, so we do still provide financial management services, although I'm not able to speak on the process, but I can connect you to who can. Yes.
So for PCHO, we hold the lease on most of our properties, and by that, we pay the full rent. The client pays, or the person pays us. So my staff, and this isn't necessarily Stephanie's role, but my staff often will then engage the person in how much they can pay and how to budget on a monthly basis. So let's say they have Social Security. They've got to pay $240 or $250 or whatever it is, right? It varies depending on how much, you know the drill. So let's say we've got a person that doesn't want to pay. We will negotiate with them, okay, let's pay $25 this month. Let's see how that goes for a few months, and then we'll work our way up to the full amount. We had a gentleman that didn't pay for a whole year. The landlord didn't have to worry about it because we were paying the full rent. But it was affecting our bottom line in terms of finances, right? That's why I fundraise. Right. But we're working on a plan with them, and any incremental amount was really, or or they lost their SNAP benefits or food stamps, right? Well, I'm taking all my money and I'm putting it towards food now. Well, let's focus on that problem and let's reorganize how we approach it. So that's essentially how we approach it. I don't know, Amy and Stephanie, if you want to jump in and talk about how you come up with creative ways, and I think solutions around reducing the need to worry about money.
So first and foremost, our agency never becomes anybody's payee. Money ruins every relationship, and the biggest part of what we do is building a relationship with our folks. If people do have Social Security and they need to pay rent and they're not paying rent, we generally make a referral to Adult Protective Services for the county. Historically, we've never evicted anybody for non-payment of rent, and we have people on lifetime plans of repayment. And that does affect the bottom line of finances, and we've had to adjust a bit in terms of how accommodating and I guess how much negotiation we can do. But typically a referral, and typically that the referral goes through, but usually there's a conversation beforehand encouraging the person to pay, and kind of that incremental, but if there isn't a change, then we do have to make the referral.
I think, like, as a peer, it's ultimately their choice what they're going to do. And the repercussions are things that we talk about. Like, you have this choice. If you decide not to, what are some of the challenges you're going to face? And some people will come down and say, okay, I have A, B, and C to pay, and this is what I want to do this month. How can I make that happen? So whether it's talking about moderation of use for that month, or you know, we have the food pantry because we all know that groceries, you need a fans only page for that. Only fans, whatever it is.
She clearly doesn't know what that is. So.
I don't. It's hard to survive off SSI or DSS. Like, you're housed, but you're still living in survival mode. So you're trying to change behaviors of stealing and, you know, boosting, whatever that looks like, selling drugs, to reduce your risk, and still manage paying your bills and apartments and becoming more responsible, and learning to trust yourself in the process. That's a huge part of being a peer, is building that trust, because when we're coming in off the streets to a program, we don't even trust ourselves. We're definitely not trusting you. There are strings attached. Something's coming, like,
Amen.
and it's terrifying. So just having a conversation with them about what they want it to look like for them and how we can support them making that happen.
Chris, do you want to add anything, or are you feeling?
No.
Okay, all right, just want to check in with you. There was a question here, and then we'll come up front.
Hi.
Hi.
Do you know of any data or studies that supports the impact of harm reduction in terms of overdose prevention and also recovery success?
Guys?
I don't have any data, I guess, but in watching harm reduction in action in supported housing, how many people have their quality of life has improved, and the amount of overdoses that have been reversed through Narcan is extraordinary, and yeah.
GMHC, do you have thoughts about that question? I figured you have the list of all those references.
Yes, so I'd like to echo what Amy just mentioned. For us, it definitely goes back to seeing the client individual successes within our programs and seeing how they really thrive once they've been through the harm reduction process and continue to be involved with the harm reduction process. So that's what we base our data in. I mean, we definitely have resources of, nationally, what are some of the rates, but that is what we focus on in our organization, what it looks like for our clients.
Okay, so I just put up, I figured it out.
Oh.
So I just put up the reference slide for Chet and Kayla's presentation. There's another page too, so I'll let that sit there for a second, and I'll change it in a second. We have a question right here.
Hi. So I just had a question in regard to educating residents, clients. Is there anything we found that when you have purpose, somewhere to go, people like Stephanie, Chris, the chances of relapse or reducing substance use is higher. So is there anything we're doing within the programs to help educate get KSACs, get master's degree, become clinicians themselves, so people can go from living and being clients in supportive housing to then working in supportive housing, and most importantly, making the same wage as everyone else around them?
I love that question. We actually just had 2 people sign up to take the peer class at a place called Recovery Fitness, which is amazing. It's a free gym. They do activities. They do camping trips. If you don't have the funds, you don't have to worry about it. They'll pay for you. So yeah, we try to engage that and share that information. We're super blessed in Rochester. We have so many resources. We have a place called Creative Wellness where you can go sculpt or do arts and crafts or poetry, like whatever you feel you need to get into that day. There's so many. And I love Flower City where we are, because we get to, someone can come down to the office and be like, having a bad day, can we go to kickboxing at 2:00? And we can go to kickboxing at 2:00, and it's like, it's a huge release for them, and that's them like building their support network, because they're meeting and networking with other places and people at these different organizations and finding different tools to put in their toolbox to grow.
Yeah, for PCHO, we work with the local KSAC training facility to do trainings for our staff, and so we'll have people come in and do those trainings. We also have interns from the local colleges often work their way through outreach and then obviously get their masters, and then they leave us. But what are you gonna do? But we support that up along the way. You want to add to it?
I'd like to point out, so our agency, for every position up to including mine, there's no educational or certification requirement. So we have an extraordinary staff who come from all lived experience situations. So I don't think we necessarily do what you were describing. I think it's just a fabric of what our agency is.
Yeah. There was a couple questions. Yeah, a question in the back, and then there's another question over here. We have about 12 minutes, but I'm game for whatever.
Okay. Hello, hi, good afternoon. My name is Byron Williams. I have a question to add to this gentleman over here. As a person that worked in the supported housing for many years, I have seen where tenants will sublet to other friends, family members, just to meet their financial need. While on your end, you're suffering the opposite financially. Is there something in protocol to combat that practice?
That's a great question. Do you have the answer to that? Because we've never run into someone wanting to sublet their apartment.
No, well.
Isn't that wild? And I don't know what we do that combats that.
Well, subletting may be to their relative. Let's say, for example, you just use a case where the drug dealer comes in and
Yeah.
he gives them, like, say, an incentive just to.
Yeah.
So I think it's quite similar to the previous situation where our agency, every single tenant, scattered site and site-based, they're the leaseholder.
Right.
And so in the lease, it states that you can't sublet. So it's a lease violation. And so kind of whatever practice and policy is around navigating lease violations.
So if the person does have the lease violation, what step do you take? Do you give them a warning and say, hey, this cannot be done? You know, you have 3 strikes and you're out, regardless of the fact that they're going to end up being back homeless again. Because at the end of the day, it's your bottom line that's being affected.
Right. So
provide more services.
weekly, if not more frequent, meetings with folks. So we start to see if there's someone staying there. That weekly communication and visit to their apartment, go through the apartment, spend time with them in their apartment, maybe cook with them in their apartment. It really prevents people from making their hold in the apartment. And I would just say there's a method that Joseph's house uses called rule, reason, and ask that is exceptionally useful for folks that struggle with understanding rules. And I'll let Amy talk a little bit about that method because we're doing that constantly, but we don't even know sometimes that that's the method we're using.
Yep. It's a simple concept, right? There's a rule, there's a reason behind the rule, and we're asking the person to follow the rule. We're not telling them, right? This is the rule, this is the reason for it, and it's usually safety-based. Most of our rules, we try to keep safety-based, and then we ask them to follow it. And it does. It
works.
It seems like a simple thing, but it does work extraordinarily well.
Right. So I hope that was helpful, but that's a technique that they use and we use that really, and the other thing is the reason behind the rule is that you are affecting other people in your community. And most people, when they come into our housing that are homeless, care more about other people than about themselves, right? Like they care more about their neighbor and the people that they slept next to at the shelter than themselves. And so if they can understand how what their behavior affects the people around them, they're less likely to do it. It's amazing, but we utilize that as a motivator. There was another question, and I'm not sure if we have to wrap up.
Yeah, hi. I was just going to say,
hi.
I've almost forgotten what I was going to answer, but someone back there was asking a question of like the evidence-based nature of harm reduction practice. And obviously the amazing folk up there that are telling their stories, from their stories they know it works. But in these areas, when you're held to account by police officers or whoever it is, that kind of evidence is complicated. Yeah, I see up there you've got one study, but there is one study that was very expensive. I think it cost about $3 million. And it was a longitudinal study with a control group of 8,000 people that were involved in street-level drug use. And it studied that 8,000 people, so a giant sample. It's a bit of a boring explanation, but it's the only study I know that there is, and it could be useful for you. And it compared them to a similar number of people who were using an overdose prevention site that practiced harm reduction. So that was a legal place to use drugs. And the study took so long, and it was incredibly complicated because you had to see where people died and how did it work out.
Yeah.
And it did show that it saved people's lives. And it came up with a number. And there's another study that showed, in terms of with this same sample, if there was treatment as usual, let's say not harm reduction, versus harm reduction, you were saving, I can't remember now if it was $5, you were saving $5 basically for the government. So I just can't remember what they're called, but they're Thomas Kerr et al., or they're the BC Centre for Excellence. So it's like
Is that the one out of British Columbia, the Canadian study?
But the two studies are just useful to say, hey, well, it actually does save lives, and actually it does save money. Because really that's all people want to know. I mean, the stories are useful, but there's pretty much no other evidence except for the beautiful stories people can tell.
Yeah.
Thank you.
Thank you for sharing that. So we have about 5 minutes, 6 minutes. Any questions? Yes.
Sorry, I don't understand.
Oh, the alone number. Yeah.
It's called Never Use Alone. You can just Google it. It's a 1-800 number, and someone will pick up. The person shares like their location. They stay on the phone during their use, and if the person goes unresponsive, then they call for an ambulance. And we're about to get like Narcan with.
I was. Yeah. So in New York, we distribute Narcan, well, at least in Monroe County. There is, they just approved, and you can get fentanyl and xylazine test strips for free through mattersnetwork.org, their website, mattersnetwork.org. If you need it, I have the website on my phone right now, and I can share that with you. But we just ordered, 600 or so test strips for outreach and for our housing programs. The more we do to educate people on what they're using, the more likely they are to change, right?
And the Never Use Alone number is 800-484-3731.
And I think for anybody that's thinking about approaching folks with Narcan and xylazine test strips and things like that, and we're saving people's lives, and in these kinds of housing programs, people aren't dying and getting re-traumatized in the housing program. So the less death that's happening in your programs, the better off we all are, right? Your staff aren't traumatized, the people next door aren't traumatized, so it's kind of simple. Yeah.
Just a quick question out of curiosity. Why did you have to take the fentanyl strips off your door? And
Do you want me to?
Are the clients really taking the strips? Because I'm under the understanding that that's going to bring down the buzz and that they're.
So.
Oh no.
So we're working on, so it's uncomfortable for some people to see that stuff on the door, and it came to kind of a concern from a management standpoint, not on our end, but we're partnering with our housing programs, so we're working through that. This is a very new program for us, and there's a lot of learning curve with that, and I think it was a little concerning to have the test strips on the door. So we're working on that. That's.
I mean,
the
yeah,
best
you
way
said
I
it
can-
better than me. I just need to add that some people feel like it's enabling or encouraging drug use when it's the complete opposite. We have people sign leases who we know are actively struggling with substance use, saying that they're not going to use drugs, and we know that they're signing this, but we also know that it's going to happen. So arming them with all the knowledge and all the tools is our responsibility too, because if we're not allowed to do that, we're kind of setting them up for failure. And we work within this system that has all of this red tape and all of these barriers that, they're hard for us. So imagine how hard they are for the people that we're serving. So I would just encourage everyone to keep talking about it, keep fighting for it. Overdose prevention centers, there's never been an overdose death there. That's amazing. Having the breathe, what are they called? I can't think of what they're called. It's like portable oxygen that you can walk around with, and that will help reduce the xylazine overdoses because xylazine is not responsive to naloxone. Yeah.
Thank you for that question. Any other questions? Well, let's give it to our panelists.